All right, I have some more interesting cases for you, and I apologize. I don't have any funny intros or funny name things. I'm pretty sick, and I'm not feeling too good. So let's get right into it. Initial evaluation completed by Dr. Bruss at 8:16 p.m. 84-year-old male presents to the ED with chief complaint of fatigue. Patient reports undergoing surgery on Monday for a kidney stone. Patient states since his surgery has not been able to eat a full meal. Patient endorses feeling nauseous and constipation. Patient states he hadn't been able to vomit but will spit up. Patient denies any pain or urinary symptoms. As usual, we don't treat an EKG. We treat a patient, and the value of any test depends on your pretest probability. This was an interesting case. It was a nice guy. He had a stent placed recently and lithotripsy for his kidney stone. He comes in, he's like, man, I just don't feel good. I'm like, what do you mean? He's like, I have no appetite. I just don't want to eat anything. Like his chief complaint was, I have no appetite. Like, do you have any chest pain? Do you have any shortness of breath, dyspnea with exertion, anything else? He's like, no, I just feel nauseous. Like, I just don't want to eat anything. His exam was like reassuring. I mean, he was a bradycardic, but his pressure was okay. No fever, anything like that. And again, like his lungs were normal, abdomen was soft, like no flank pain or anything like that. All right, so here's his previous EKG. Again, I recommend you pause, go through the EKG, write down your findings, and think about what your interpretation is. All right, so here's what I see. As usual, I start with the rhythm strip down here. I do see one P wave for every QRS. Let's just extrapolate that up to make sure, because this is kind of a crappy reading. There's a P wave, there's a P wave, totally a P wave. Yeah, these all march out. So one P for every QRS, so we're sinus. As far as the axis goes, it's short, but it's up in AVF and up in 1, so a normal axis, okay? For the intervals, the QT is not prolonged because it's not more than halfway between each R wave. For the QRS duration, I mean, I would defer to the machine for this, but it does not look longer than 3 boxes. So it's, and I would qualify this as an incomplete left bundle branch block with this downward appearance in V1 and V2. The thing that points against that is this large R wave in V3. I mean, technically, it's not abnormal R wave progression because abnormal R wave progression is an R wave less than 3 millimeters. And this R wave is definitely more than 3 millimeters. This drastic jump, going from 0 to over 5, plus 5, I mean, that's not normal. Now, is it pathologic? Not necessarily. For me, that would make me concerned for right ventricular hypertrophy or pulmonary hypertension. I mean, that is kind of indicative here in V3 and V4. I mean, mostly you see right ventricular hypertrophy or pulmonary hypertension in the precordial leads like V1, V2, and V3. And what you're looking for is what we see here, like this large R wave with this J-point depression. I mean, it's very slight, but there's maybe like 1 millimeter of J-point depression from the PR segment in this lead. And we have the same thing up here in V4. I mean, there's large R wave and this very slight J-point depression in this lead. Again, it doesn't technically qualify because it's not in these two precordial leads, but this drastic change in these two contiguous leads makes me suspicious for right ventricular hypertrophy and or pulmonary hypertension. Sorry, I got distracted there. Where was I? I did rate, rhythm, axis, intervals, ST waves. All right, let's go through and look at the J points. Again, this lead these tracing is not the best, but here's the PR segment. Here's the end of the QRS. I don't see any significant J-point deviation. Same thing here in lead 2. This, again, is suggestive of what's called, the reverse delta. Okay, the reverse delts, which we talked about before, can be associated with mitral valve prolapse. Down here, I don't see any J-point deviation. There's no R wave, like it's just straight S wave, and there's flattening of the ST segment here. Again, non-diagnostic, but something that technically is different from a normal EKG. Down here in AVF, I don't see much J-point deviation, and I do see this, again, fractionated QRS here. This RR prime in the QRS, but again, it's not a bundle branch block because the QRS duration is less than 120. Similar things here, it being on the back side of the QRS in AVF would make me suggestive for mitral valve issues. Here in AVL, I don't see any significant J-point deviation. The T wave is upright, which we always like to see. Again, slurring of the S wave, but not a block. Up here in AVR, I'm not seeing much J-point deviation. This could make me concerned for linearity here, but it's tough with the tracing. And again, this is just a previous EKG to establish a baseline. We're not making a diagnosis from this one. Again, I don't see much J-point deviation up here in V1. I do appreciate this linearity here, which is definitely greater than 1/4 of the M to the QRS, which can pique my interest in the proper setting. In V2, I don't see much J-point deviation, but one could make the argument that this could be consistent with a hyperacute T wave, as this T wave is definitely over half the amplitude of this QRS. Again, that's not a set rule from the literature, that's just my rule of thumb. Again, this is just to establish a baseline, but in the proper clinical setting, that could make me concerned for coronary artery disease. We already talked about V3 with the large R wave and slight J-point depression. Again, a little peaky T of the T wave here, but again, I wouldn't qualify that as hyperacute because its relative size to the QRS is not really that relatively high. Same issues here in V4 that we talked about. Large R wave with some ST depression. Again, there's linearity here of this segment. Slight J-point depression here. And again, linear of this ST segment. And same issues here. There's not real much J-point deviation, but there is inversion and straightening of this ST segment, which is over half the amplitude of this QRS. And there is some slurring of the S wave down here, again, suggestive of structural heart disease. So my overall findings is normal sinus rhythm with a normal axis. Borderline incomplete left bundle branch block, but I'm not too confident in that. There are suggestive signs of either pulmonary hypertension, right ventricular hypertrophy, and or structural disease, and there's nonspecific S2A abnormalities which are non-diagnostic, especially with the absence of me having no history. One other thing that catches my eye up here before we move on is if you notice, it's very slight, but there is technically a T wave in V1 that's bigger than V6. Okay, remember when you have that, especially when it's new, that loss of precordial T wave balance, that can be an early sign of an LAD pathology. Okay, so that's just to establish the baseline. Here's the first EKG when I saw him. Same thing, I recommend you pause, go through it, write down your findings, and think about what your interpretation is. So, here's what I see, starting with the rhythm strip. I'm looking for P waves. I'm not seeing much here. Am I seeing, maybe there's one right there. Maybe there's one there. Hard for me to tell. Remember, the best place to look for P waves is lead 2 and V2. I'm not seeing much up here. Maybe there's a questionable one in there. Does it extrapolate out? Maybe. Aha, let's look here in V2. This is a clear-cut P wave. I hope you all agree. So let's extrapolate that out. Let's follow this down. There's a P wave. Okay, let's follow it down. There's my P. Okay, not this question mark. That's my P wave. Okay, now let's see if we can march them out. There's one P. Here's another P right here. Okay. Oh, I don't like that. Look at that. We have this P with a very short PR interval, another P. Okay, and there's a delay with a QRS. Let's see if we can map out. So let's see. We agree that's a P wave. I agree that's a P wave. So here's our P to P interval. Let's see if we can map this out here. So let's see, 1, 2, 3 big boxes. So 1, 2, 3. Let's see, is there a P wave down in there? I don't know. Up here, possibly. Let's go up. Yeah, I see that little notch up there. I do see this little notch up here, which is different than this one. Look at this T wave here, and then look at this T wave for this speed. Okay, anytime, I call these polymorphic T waves. Anytime you have T waves that look drastically different, oftentimes there's a P wave buried in there, and that's what I think is going on here. So let's extrapolate this out. So there's our P to P interval. There's another P. So 1, 2, 3, 4 boxes. There should be another P somewhere in here. Let's look up. I'm not seeing much. Is there? Ooh, that could be a P there. Oh, okay. Yep, there's a P. Okay. Let's extrapolate it out. 1, 2, 3, 4. It should be somewhere around in here. I'm not seeing much. Let's look up. There's a blip. Not much. There's a blip that matches with that blip. Oh, and look at that. There's another blip. Okay. So we have our P to interval. And I'm not saying, because the problem is here, I can't definitively see these clear-cut P to PR intervals. With me, I'm calling this a complete heart block. Because there's literally no change in the P to P interval, and there's no change in the R to R interval. The R to R interval is staying the same. And again, when we look down here, we see these different morphologies of these QRSs, correct? Look at this one, and then look at this one. We see it up here as well, right? Look at this QRS, look at this QRS. They're equidistant apart, but they're morphologically different. My opinion is, well, that has to be from a buried P wave in there. And like doing some detective work, again, like here, I think there's a P wave there, and if we march it out, there's another one there. Like that's, I mean, is it definitive? It's hard to tell because this tracing, but that's how I came up with this rhythm abnormality on this EKG. If you like it, great. If you disagree, bring it up to me in person and we'll talk about it. All right, so that was a complicated rhythm. Access, let's see what we got. It is mostly up in AVF and mostly up in 1, so normal access. For the intervals, again, I would defer to the machine, but just eyeballing it, I don't see prolongation of the QTC. For the QRS, I do see prolongation. Like it's definitely longer than 3 boxes, okay? It's down in the precordial leads, so it's consistent now with a complete left bundle branch block, okay? For the ST waves, let's look at the ST segments. Now, we have a complete left bundle branch block here, right? So when we're thinking about our findings and our interpretations, we should not use the terms elevation or depression. We should be using concordance or discordance. So up here in lead 1, I do see some J-point deviation downward, which is appropriate discordance in this setting. Again, it's difficult to see where the QRS ends, so let's follow it down here. Here's the beginning of the QRS, the end of the QRS. Is that some concordance? It's very difficult to tell. Up here, I don't think it is, because here's the clear ending, and I think this little blip is all within the QRS. So I'm not calling much J-point deviation there. Here we do see it. Like we see J-point deviation, but again, this is, well, you can make the argument this is inappropriate discordance, right? I mean, because the amplitude of the R wave here is about 1, 2 boxes down, and the amplitude here of this discordance is about 1, 2, 3 boxes up. You could make the argument that that's inappropriate discordance in the setting of the left bundle. Also note the morphology of this ST segment here, this linearity of it. Up here in AVR, maybe slight J-point deviation, but again, appropriate discordance. Again, here in AVL, like I'm always yelling about this inversion and depression in AVL and being a sign of coronary artery disease, but that's because it's a left bundle branch block here. Okay, this is not, the depression and inversion I'm always going on about. This is appropriate discordance. And remember, we have to use like the proper terms when we're explaining these things. Again, here, I don't see much J-point deviation. I think this is mostly within the QRS. Here I do see appropriate discordance. As well, I see disappropriate coordinates here. One could make the argument for a hyper-acute T wave as this is approaching over half the amplitude of the QRS. I do see some, it's pretty straight here, but no concordance. Over here, maybe slight concordance, like a quarter, but nothing to concern me. Line up pretty straight there. And again, I do think there's no concordance here. This is all within the QRS. So my overall interpretation for this is it's a third-degree heart block with a complete left bundle branch block and diffuse nonspecific repolarization abnormalities with borderline modified Smith criteria for an acute infarct. But remember, we don't treat an EKG routine a patient, and what did this patient come in for? He came in because he had no appetite. And I really grilled him down. I was like, are you sure you're not having anything else? Like no heartburn, no tightness, no back pain, no nausea, like no nothing. And he's like, no. I'm like, when you exert yourself, do you get any symptoms whatsoever, like anything? He's like, no, I just have no appetite. So a little while later, I repeat the EKG because the first one was so crappy. Again, this is not the best one, but let's go through it. Again, here's our rhythm strip. Where are our dadgum P waves? Now we have to do this whole thing all over again. Okay, here we are in lead 2, questionable P wave, questionable. Let's look over here. Our good old buddy V2 didn't let us down last time. Okay, this clearly is a P wave. Okay, P wave. Okay, now let's see if we can do some detective work and see if and where we're dropping one. I do think this is a P wave, and I think this is a P wave. There's our P to P interval. Okay. So there should be another P wave buried somewhere in here, which I do think we see up here as well. And this kind of weird deflection here too, maybe down in there. And there's a P. Now that we have our P to P interval, we can kind of map out where the dropped ones are. Again, so the P to P interval does not change. The R to R interval does not change. So in my opinion, a complete heart block. For the axis, up in AVF, up in 1, so normal axis deviation. For the intervals, again, I would need the machine, the eyeball test. We're getting close to prolonged QTC. The QRS on this one is approaching like 2.5 to 3 boxes. So again, left bundle branch block appearance. Let's see what else we say. And again, like note this changing morphology as we look through here of the QRS complexes, right? Like look at the morphology of this QRS complex versus this one. Same thing down here, the morphology of this one versus this one. I mean, that tells me because there's buried P waves in there. Like these P waves are buried in there. We have to kind of map out where they are. So again, a complete, in my opinion, complete heart block with a left bundle branch block. I mean, there's definitely needs intervention with cardiology and can be concerning for acute onset of coronary artery syndrome. But again, remember, we don't treat an EKG or a patient who's having no chest pain or anything like that. So in the process of his workup, of course, his troponins were elevated. I called cardiology. They came on down. They said, hey, we're going to page out a STEMI. And I was like, dang, I failed that one. Like my times are going to be off. And I didn't tell him, but I'm like, I don't think it's acute infarct, but I agree, it's taken to the cath lab. And so the conclusions, patent, Lima, and 3-vessel to OMG, diagonal, and PDA. No large culprit identified. Discussed with the doctor for a distal RCA to PLV, but given the potential small territory, he recommended medical therapy. But they did successfully put in a pacemaker. And for the ventricle, left ventricle appears normal in size. There is mild increased wall thickness, hypertrophy. Systolic function is mildly decreased with ejection fraction of 45%. See wall score diagram for wall motion abnormalities. Now, we do have wall motion abnormalities on here, which again is concerning for an acute infarct. But if you remember, this patient had a bundle branch block. Okay, bundle branch blocks do give you wall motion abnormalities on an EKG. So that can be a difficult thing if you have someone with a left bundle branch block and you're trying to determine if they need acute intervention, and what you're using to determine that is wall motion abnormalities on your bedside echo. If they have an underlying bundle, that might confound the results and what you're going to do. So just keep that in mind. Right ventricle size is borderline dilated. Diastolic function is normal. Remember, like we talked about before with that amplitude of that R wave in his previous one, that made me concerned for right ventricular hypertrophy and pulmonary hypertension. Also diastolic mitral regurgitation. It can be seen with an incomplete heart block, but again, we saw a reverse delta on the EKG. Here's case number 2. Again, one of mine. 75-year-old male presents to EE with chief complaint of bradycardia. Theme here. Patient reports seeing his PCP and brought up his bradycardia. He states during his routine physical, his PCP took his EKG, which showed bradycardia. Patient also reports undergoing a test today to check how his heart rate responds to increased activity, which was a stress test. He states that his heart rate did not increase as much as they thought it would, so they send him to the hospital for further evaluation. Patient reports noticing more body aches and burns that come with physical exertion. Patient denies any dizzy, lightheadedness, or weakness. Patient also states he regularly gives blood and noticed that last time it took him longer than usual to donate. This was an interesting case. There's a nice guy, like relatively healthy guy, not a lot of medical problems. He'd been walking around like this for about a month. Like he saw his doctor, and his doctor, did an EKG. He's like, I'm not too worried about it. Let's set you up for a Holter monitor and a stress test. So he went to get the stress test, and they're doing the stress test, and the cardiologist's like, you need to go to the ER. Like, he didn't tell him why. He was like, you need to go to the ER. So the guy walks in, like his pressure's fine. Like he's talking to me, like his color's fine. He's like, hey, can I have something to eat? And his biggest concern was that it took him longer to give blood. Like, he's like, yeah, all these tests and stuff, my doctor. And he's like, but you know what? Like, when I give blood, it normally takes me an hour, but like now it takes me like 3 hours. Like, what's the deal with that? Like, that was the most concerning thing to me. Like, he was very upset about that. All right. So here's a previous EKG for this gentleman. Again, we're doing this just to establish the baseline. There might be many abnormalities on here, but what to make of those, I can't really do that because I don't know, what his symptoms were, what his presenting signs when he had this EKG. So let's just, work on our skills and practice as normal. Here we have the rhythm strip down on lead 2, P, QRST, 1P for every QRS, sinus, the rate looks normal. All right, we're all done. Let's look at the axis, up in 1, more down in AVF, so we have a left axis deviation. If we look over here, we do see it's more down in 2, 3 in AVF, and it's up in lead 1 in AVL. So we have a left anterior fascicular block. Okay, for the fascicular blocks, the anterior and fascicle blocks, They concern me in number one, if it's acute onset with coronary artery symptoms, that can be concerning for acute coronary syndrome. And number two, when you have a fascicular block in conjunction with a right bundle branch block, when you have that bifascicular block appearance, that's also concerning. And you'll be able to, even if you don't recognize the fascicular blocks, if you remember, for a right bundle branch block, you should not have axis deviation. You'll pick that up regardless. If you see a right bundle with an axis deviation, then by default it has to be a fascicular block as well. All right, so axis intervals, we picked up on the fascicular block. The QTC, to me, does not look prolonged. Like, I don't see the T wave falling in between each R wave. For the QRS duration, it's not over 3 boxes, so it's narrow. For the ST segments, let's see. I don't see much J-point deviation here in lead 1 or lead 2. Sorry about the phone. I record these on my kid's computer, and it's his cell phone. I don't know how to turn it off. I don't see much J-point deviation in lead 3. I don't see much in AVR. Ooh, I do see this inversion in linearity in AVL. That's concerning, right? That's always concerning for me. Again, it has to be relevant to what's going on, but that's always concerning to me. I don't see much J-point deviation in AVF. Same here in V1, not much J-point deviation, and we're close, but V1, V6, I mean, they're about equivalent. We don't have loss of arbitral T-wave balance. Not much J-point deviation there, or in V3. I mean, maybe hyperacute T-wave in the proper setting. Here we go, not much J-point deviation, but definitely you can make the argument for hyperacute T-wave here, right? Like this whole QRS can fit under there. That's an Amalma-2 thing, definitely hyperacute. Same argument here. Like, do we have J-point deviation? Yes, we do. And we also have this like hyperacute T wave here as well. Maybe slight J-point deviation, the slurring of the S wave, but nothing too concerning. So my overall interpretation is normal rate, sinus, left axis deviation, left anterior vesicular block, non-specific repolarization abnormalities, which are non-diagnostic without a history and physical exam. So remember, that was just to establish a baseline. Let's go on to the EKG when I saw him. Same thing, let's start with our rhythm. Here's our good buddy lead 2. Okay. Is that a P wave? Could be. That's totally a P wave. There's a QRS, there's the T. Is that a P wave? Is that a P wave? I don't know. That's a P wave, QRS-T. There's a P. No T, no QRS. There's a P. QRS-T. There's a P. There you are, you jerk. I see you hiding in there. Okay. So we have a P to P interval that does not change. Okay. And we have one dropped QRS here. And when we look at our PR interval is staying the same. Okay. So this is a second degree type 2 where the PR interval does not change and you're just dropping every other beat. So there's our rhythm. Our rate is bradycardic. Where are we at? We're at 1, 2, 3, 4, 5, 6. 6 times 6 is 36. At least I hope that's what the math checks out to be. I'm not a human calculator. Don't judge me. So it's bradycardic with a secondary type 2 block. It's up in lead 1 and down in AVF. So left axis deviation. Again, we have this left anterior vesicular block, right? Up in 1 in AVF and down in 2, 3 in AVF. I mean, that's concerning, right? I mean, we have a AV nodal block and we have a vesicular block too. That's not good. That's concerning. Let's keep going. For the intervals, the QTC, again, I would have to refer to the machine, but I don't think it's prolonged. The QR is prolonged, though. Like, it's greater than 120, and we have the RR prime with precordial leads, so we have a right bundle branch block. This guy is the mayor of Block City, okay? AV nodal blocks, vesicular blocks, and now a bundle block. Ooh, that's not good, right? I mean, that's totally unstable. Like, this guy literally only has one component of his electrical activity that's still working, and he's been walking around like this giving blood for 3 months. Crazy. Again, so let's look at our ST segments. Again, we have a right bundle branch block here, so don't try to use Scarposa's terms. That's unforgivable sin. Not seeing much J-point deviation in lead 1, maybe slight in lead 2, looks good in lead 3. AVR, I'm not seeing much J-point deviation. Again, for the right bundle, always keep track of where your QRS begins and ends. Some could be tempted to call this J-point elevation or ST elevation. It's not. it's still one component of the QRS. And one could also make the argument that this is a terminal R wave, okay? As we have an R wave greater than 3 millimeters or an R to S ratio greater than 1. Okay, those are the two waves to define a terminal R wave. Again, a terminal R wave is a relatively finding. It's not always pathologic in itself, but when you see it, it can be highly concerning for sodium channel pathology as well as connexin 43 conductive pathology problems as well. Again, I don't see much J-point deviation up in here in V1. I do see this inversion in V1, but remember, slight T-wave inversion or ST depression in the pectoral leads is okay in a right bundle branch block. Not much J-point deviation in lead 2. I don't see much in lead 3. Lead 4, I'm not seeing much J-point deviation, neither in lead 5. Again, I do see these hyperacute T waves in this leads, okay? And again, not much J-point deviation, but a relative like hyperacute T wave. So my overall interpretation is this is bad. It's bradycardic due to blocks, like a second degree type 2 AV nodal block, a left anterior vesicular block, and a complete right bundle branch block. There are diffuse nonspecific repolarization abnormalities, but again, nothing diagnostic. Now, a couple things here. The first thing when I was looking at this is I was like, well, are these things behind the QRS, are these P waves or are they U waves? And the thing is, if it's a U wave, it should be morphologically different than the P wave. Like these, I mean, it's tough because the tracing is so bad, but when we look up at these, like morphologically, they're the same, right? Like there's the P wave, like that's also a P wave, like clear cut here as well, right? Like morphologically the same. Like look at this. I mean, the tracing's kind of bad, but this is like 1/4 millimeter and it's straight. Like same thing here, 1/4 millimeter if it's straight. So, I mean, that's why for me, that helped me distinguish between why this is not a U wave. It's actually like a P wave that's being blocked. And the other thing is, you know, people are like, well, is this a secondary type 2 or is it a complete? And it just so happens that the QRSs and P waves are lining up so it looks like there's a PR interval that stays the same. I would say, well, yeah, I guess theoretically that's possible, but clinically does it matter? Like, no, a third degree and a secondary type 2 are treated the same. I mean, they both are going to need intervention, but the first question is, are they stable or unstable? And that's the clinical teaching point for both of these cases. When you have a bradycardic patient, the first question in the emergency room is, are they stable or unstable? If they're unstable, the thing you look for is electricity. Like any unstable arrhythmia, the best treatment is electricity. And all that differs is, well, how you dose and apply the electricity. For ventricular tachycardia, those things, it's a synchronized cardioversion. In this case, you're giving them a dose of electricity as pacing, either transcutaneous or transvenous pacing. I always like to do transvenous pacing because it's much more humane than transcutaneous pacing, but that, again, depends on where you're at, what backup you have, and your skill level. But the first thing you do is if they're unstable, you pace them. If they're stable, then you look for the reversible causes. The most likely ones is, always remember, hyperkalemia is notorious for causing bradycardia. Hyperkalemia can do whatever it wants. It's the syphilis of EKGs, as Amalmatou says. The other one, especially for older people, would be medications, specifically beta blockers, calcium channel blockers, and or oral hypoglycemic medications. Neither of these patients had either one of those, by the way, and they both got admitted and got pacemakers and did well. So those are the cases I have for this. I hope you find those interesting. The short story is they were both bradycardic cases, and the problem was discerning the P waves. And we had to do a little bit of detective work to come to the answer. And was our answer completely correct? Maybe not, but clinically at the end of the day, it didn't matter what happened with the patient. Like, don't lose sight of the forest from the trees. Like, yes, we're talking about all this EKG fancy stuff, but at the end of the day, we're treating a patient. Like, what's going on with the patient? What does he need? And how do I get to need him to go there? That's all I got for this one. Hope you enjoyed. Peace out.